Good day and welcome to all for the session on prevention of infections in neonates. I'm really looking forward to the next 3 days where I can interact with more than 1,000 nurses, primarily from Kerala, but I'm sure there are many who are across the globe. So today we will discuss one of the most important aspects of newborn care, that is prevention of infections, and that is truly all in our hands. Infections is like the big elephant in the NICU. It is the big killer, and in fact, it's one of the 3 most important causes of newborn mortality. And this is definitely totally preventable. We know various means of how to prevent infection, but the big problem is putting these things into action to implement them. So how do we really bridge this gap is what we're going to be discussing today. The first thing is to have a change in the mindset. Very often we think that, especially in the very small preterm baby, infection is inevitable. We need to remember that every infection a baby has is preventable. And to make this change, we have to approach it through a quality improvement pathway. So the first thing for us is to have zero tolerance to infection and understand why every infection occurred and what we can do to prevent it. So today, we will be discussing what I think are the 10 most important steps for prevention of infection, and we'll be discussing each of these in detail. The first and foremost, as all of you all know, are safe, clean hands. Literally, the outcome of our babies are in our hands. And hand hygiene is one of the most important aspects of infection prevention in the NICU. In fact, even if there's infection everywhere, our hand hygiene must be so robust that it doesn't reach the baby. Something like how we have in the airports, where the airport security check is really very good. And it was Semmelweis, whose photograph you see here, who showed us this pathway, who showed that by a single intervention of hand hygiene, the mortality among postpartum mothers could be really decreased to a significant extent. Hand hygiene can be either with the use of a hand rub or by hand wash. With a hand rub, it is always an alcohol-based hand rub, which contains around 60 to 95% alcohol, with or without chlorhexidine, whose addition is beneficial. And you need to do this hand rub for at least 20 to 30 seconds. And you need to take at least 3 ml of hand rub in your hands. When you take a hand rub, please note that you should not be pushing the nozzle with your fingers, but rather use your elbows or any other part which usually doesn't come in contact with the patients like this and take the 3 ml of hand rub. Most often, one push is 1.5 ml. So that means you need to have 2 pushes of the hand rub. Hand wash is the other alternative. And you need to do hand hygiene as per WHO recommendations of at least 40 to 60 seconds. But please remember that when you're entering into the NICU, the hand wash should be at least of 2 minutes duration. When do you do hand wash as compared to using of a hand rub? Whenever the hands are visibly soiled, before doing any procedures, before giving medications, before giving food, after using the restroom, hand wash is mandatory. If you touch a baby who has definite infection, then again, you need to do hand wash. If you see the pamphlets and these posters of hand wash and hand hygiene, there are 6 core steps which are extremely important and which are vital, which are common for both hand hygiene use and hand rub use. And these are the 6 steps that we need to do for the minimum duration of 30 seconds with a hand rub and at least 40 to 60 seconds with hand hygiene. If you see here, it also shows how you can close the tap, and then you need to dry the hands and close the tap. But preferably, if we can have an elbow operated or a foot operated tap in the NICUs, that is better than something that you close the tap on with your fingers. For every baby, we need to consider the environment around the baby as his or her own. And even when we enter into the environment or come out of it, we should do hand hygiene. So the 5 movements of hand hygiene are before touching a patient, before clean aseptic procedure, after body fluid exposure, after touching a patient, or after touching the patient's surroundings. Now, this is very important because most of us definitely do a hand hygiene before we touch the baby. But many times we forget to do that when we have to alter some settings on the ventilator, or when we need to touch the pulse oximeter. We forget that it is as important to do hand hygiene before we touch the baby's environment as when we touch the baby. And hand hygiene is something that most hospital infection control committees always audit in all the high-risk areas like the ICUs. And if you see any hospital, most of the time, it is the NICU which comes out tops. The hand hygiene compliance is usually best in the NICU. And that was true even in St. John's. But when we started doing the hand hygiene audits ourselves, we found, and that is published in one of the papers, that our compliance with hand hygiene was next to 0%. So how did we have such a difference between the audits of the HICC versus what we did? And this was because with HICC audits, whenever we did any hand hygiene, and it was most of the time like this, it was considered as hand hygiene done. But when we started doing the audits, we focused on the 6 core steps. And when they were not done, or when the duration was not appropriate, we considered it as hand hygiene compliance is poor. And therefore, it's important that in addition to the HICC audits, your team in the NICU does audits for the NICU on their own. It is not enough to do audits and then blame people and try to tinker and tell them that you need to improve. There has to be system changes. For example, in our unit, if you see here, just next to the warmer, we have a hand rub which is available so that we can remember, and it is easily accessible when we go to the baby. So it must be, if you place it somewhere else where you have to bend and do those things, then people may not really use it. Similarly, we need to ensure that we have adequate numbers of all this. And here you see our weekly indent for hand hygiene for hand rubs. And unless we give the bottles back, we don't get more back. In fact, this can be an audit. How many are you using in a week, and whether that has decreased, increased will also tell you the compliance with your hand hygiene. Hand hygiene is a behavioral is a behavior that we need to modify and improve on. And therefore, motivation is extremely important. So continuous training, and some of these posters, I find them very interesting. And in fact, our nurses say a prayer every day in the morning, where one of the things they say is, God, let me not give infections to the babies with my hands. So this kind of motivation is good. And at the same time, psychological safety in the NICU is extremely important. What do we mean by psychological safety? This is where anyone in the unit, whether it's a nurse, whether it is an aide, whether it is your Class C worker, has the confidence of pointing out errors or mistakes or some breach of protocols and highlighting it without fearing that they will be either punished or they will be made fun of. So this is a kind of psychological safety that every NICU needs to harbor if any of our quality improvement projects need to work. The other reason is dermatitis. We find compliance with hand hygiene can be poor because when we are working in the NICU, if you're a very diligent worker, because of the repeated hand wash and hand rubs, you do sometimes develop dermatitis. It can be because of the brand. Sometimes when we get a new brand, and in such cases, we have changed the brands. Also, it's important that we who are working in the NICU take care of our skin, especially during the time when we are not in the NICU. Use of a moisturizer or something like that will be really helpful. Also make sure that you dry your hands before donning your gloves, because that also could lead to dermatitis. So the most important message, the first message is that infection prevention is in our clean and safe hands. The next thing that we come to is bundle care. What is a bundle care? Of course, babies are bundles of joy. But bundle care means multiple interventions that are done nearly simultaneously to address one or more interrelated clinical problem. And here we have many examples of bundle care in the NICU, and I'm going to start with a peripheral line bundle because it is one of the most common things that we use. In peripheral line bundle, which we have developed in our NICU, we have an insertion bundle, a maintenance bundle, and the removal bundle just states that you should remove it as soon as possible. So the insertion bundle looks at a checklist, hand hygiene, site preparation, aseptic non-touch techniques, number of attempts, and so on. And maintenance bundle is scrubbing the hub, use of a Q site or a needleless connector, monitoring the site, and so on. Aseptic non-touch technique is extremely important, and this is not only true for peripheral line insertion, but also for other procedures, where hand hygiene is a core, but it also includes correct glove use, key site protection, non-touch technique, key site disinfection, and aseptic field management. So please, before you start putting a peripheral line, keep everything ready. Have a sterile area, a disinfected area. Make sure that the area under the baby's limb that you're going to be putting a peripheral line into is sterile. You can use something as simple as the paper cover in the glove, which is sterile, to place it under the baby's hand. The site where you're going to be inserting you should ensure that this site is adequately cleaned, disinfected, and you don't go on poking it just before you're putting in the needle. So that's what we mean by a non-touch technique and key site protection. Similarly, the needle that you take, the cannula that you take should not touch anywhere else. You need to take care of that. And then ensure that the whole process is done in as sterile a manner as possible. And here you see our HICC team of the NICU training all the nurses and the residents. And in fact, we have a checklist which we will be sharing on this group that you can see or even use. Similar to the peripheral line bundle, we have the CLABSI bundle and the VAP bundle. VAP means ventilation associated pneumonia, any new onset infection in a baby who has been mechanically ventilated for 48 hours should be considered as VAP. And here again, we have an intubation bundle, maintenance and extubation bundle. Similarly, CLABSI means a central line associated bloodstream infection. So any blood culture which is positive, where a central line has been in place, or within 48 hours of its removal is considered a CLABSI. Here again, we have an insertion, maintenance, and removal bundle. In 2015 in St. John's, we started a quality improvement program to reduce infections. And one of the main reasons we found was babies with central lines. And therefore, we focused on it. We had a written protocol. We said insertion of a central line is a privilege, that only residents who have seen and assisted 5 central line insertions can do. We developed a checklist, and we also had a central line card which we pasted on the baby's warmer, where every time the central line was breached, someone had to tick in that, and we also had audits for the same. Some of the things we included in our bundle is that we said we'll have only a single port in the central line. We ensured that there was a Q site, and scrubbing the hub was a very important aspect of the central line maintenance bundle. And we used to do it, we do it with chlorhexidine. If you see here, 15 seconds of scrubbing the hub is essential to ensure that the hub is free of any germs. And after 15 seconds of scrubbing, you have to give another 30 seconds for it to dry before you enter into the central line. The same thing is applicable even for a peripheral line. In the VAP bundle, while doing the endotracheal intubation, of course, you take all aseptic measures, but once it is put, please ensure it's fixed well, and you keep on monitoring it so that you don't have accidental extubations. And the endotracheal tube should be in a sleeping position and not upright so that any secretions or condensation doesn't go and enter into the baby. Humidification is extremely important. Use distilled water with an autofill technique. Drain the condensate often, and change the humidifier every day. Most of these aspects of the VAP bundle are taken from adult medicine. And it also says that you give a head and elevation of around 30 degrees. And ET suction, please remember, should be done only when necessary, when the baby is agitated, when there are secretions, and it's always a two-person's job. In our unit, we prefer to have an inline suction for a baby who is ventilated for a longer duration, and it should always be a protected suction. We avoid normal saline. For all these babies who are nil by mouth, we do use colostrum for oral care. But the most important aspect of the VAP bundle is to get the baby out of the ventilator as soon as possible. And we have a great alternative for babies who are not very sick, and that is CPAP. Any of these bundles, any of these measures, unless you audit them, things will not improve. So we have audit sheets, which again, we will be sharing with you on hand hygiene, CLABSI, VAP, and so on. The next most important thing is breastfeeding and kangaroo mother care. Having the mother in the NICU is one of the most important interventions to reduce infections in the NICU. First, and common sense is that she's going to be there to continuously monitor her baby. In addition, breast milk is really a nectar. Early enteral feeding is very helpful for the babies to prevent infections and early discharge. In fact, there are a lot of papers now which states that any baby more than 1,000 grams and who is not very sick can be started on full enteral feeds from the word go. And exclusive breastfeeding, even in the smallest of the small babies, is beneficial and recommended. So colostrum, please remember, is not a nutritional intervention. It is an immunological intervention, and every baby, whether term, preterm, should get colostrum. If the baby can't take it orally, at least smear it into the baby's mouth. And start feeds as soon as possible. And we have seen in our unit that the greater the nil per oral days, greater is the bloodstream infections which occur. There is definitely a correlation in keeping the baby nil by mouth and infection, because whatever you do artificially could be a source of infection. So get the babies to feed as soon as possible. And when the babies are on IV fluids, please ensure that all aseptic precautions are taken while IV fluid is being prepared. Again, IV fluid preparation is always a two-person's job. Should have a protocol on how to do it. And even if this is not TPN, just plain IV fluids, if you have a laminar flow, it is best to prepare it under the laminar flow. Breastfeeding is protective for necrotizing enterocolitis, which we all know is devastating and can kill babies. If you feed 10 preterm babies with exclusive breast milk, you prevent 1 NEC. That is the number needed to treat. Similarly, if you feed just 8 babies, then you prevent 1 NEC which requires surgery. Even if a mother is not able to provide full milk, you need to motivate her so that she can go on increasing it. For every 10% increase in the use of breast milk, the NEC rates decreases by 0.83. For 25% increase, NEC risk is reduced by 38%. So very strong data to say that breastfeeding is a way to reduce necrotizing enterocolitis. In our unit, we have an NEC bundle 2, which consists of hand hygiene, fluid restriction, colostrum oral care, lactation promotion, which itself is a big intervention to ensure that all preterm mothers are able to give milk for their babies. Trophic feeding, early feeding, protocolized feeding. We do use probiotics to decrease NEC, but that is in the smallest of the small babies, less than 1,200 grams. Aseptic non-touch techniques, even for milk preparation and feeding, kangaroo mother care, and donor milk. If you're one of the lucky ones who has a breast milk bank, nothing like it. That is what we need to ensure that we give human milk to the babies. Kangaroo mother care is the other big intervention which reduces infections in a big way. From the Cochrane meta-analysis, we know that kangaroo mother care reduces sepsis to an extent of 65%. And in fact, kangaroo mother care makes the non-specific immunity of breast milk very baby-specific. And let me give you an example of how it occurs. For example, if this tiny baby is in the NICU and you have Klebsiella quite rampant in your NICU, this little fellow can't really produce antibodies to Klebsiella because he's immature. But if the mother is able to come into the NICU, she's exposed to the same Klebsiella, she can definitely mount a response. And if this baby is colonized with Klebsiella, this mother gets that, she produces antibodies, gives it to her baby, and now this baby has specific anti-Klebsiella antibodies. So see how beautifully Kangaroo Mother Care makes the enteromammary immune system of breast milk baby specific. In fact, now we know that Kangaroo Mother Care is not only for the stable babies. We have just finished a large study sponsored by WHO across 5 countries in India and Africa. And here you see the mother newborn ICU, which is going to be the paradigm shift for our NICUs. Not just baby beds, but mother adult beds, where even for the sick baby, the mother is by the side. Doing this intervention and starting Kangaroo Mother Care as early as a few hours after birth, even in the sick infant, has been found in this study that it reduces sepsis by an additional 20%. The comparative group in this study was babies who received good KMC. In fact, in both the groups, the control group also did very good KMC of almost up to 17-18 hours per day, but they started it a little later once they were stable. So therefore, Kangaroo Mother Care, early KMC, early breastfeeding, these are the definite ways of reducing sepsis. The next thing is quite a paradox, that is antibiotic stewardship. On one hand, we know that antibiotics is a treatment for sepsis, but at the same time, a baby who remains on antibiotics for more than 5 days is himself at greater risk for infections, late onset sepsis, and NEC. This is because these broad spectrum antibiotics kills the normal good bacteria in the baby too. And therefore, decreasing antibiotic use, ensuring it is optimally done, is one important intervention to reduce infection in your NICU. And that is what we did as another quality improvement project. One important aspect was curtailing antibiotic usage. A great reluctance to start. The baby has to earn antibiotics. We looked at our antibiograms and all, and then decided that we will go with a single drug amikacin, and that's what we have been doing for some time. Emphasis on stopping and de-escalation. If the baby is well and your cultures are negative, baby has no business to be on antibiotics beyond 3 days. And sending a blood culture for every baby who's on antibiotics before you start antibiotics is good. Is a good intervention, and it must be done. Unfortunately, many of our SNCUs don't have blood cultures. And when you send a blood culture, please ensure that you send at least 1 ml, because this is required to grow the bugs if there are any. Many outborns are already on a cocktail of meropenem, vanco, and all that when they come. And in such babies, we downgrade straight away and then look at how the babies are, and we follow up their cultures. But these babies, when you downgrade, you need to be very, very careful and monitor them. Similarly, once we get cultures, you need to downgrade antibiotics. For example, if a baby was on meropenem and the blood culture comes out as that the bug is sensitive to, say, piperacillin, you need to downgrade to piperacillin and not continue meropenem and say, anyway, 3 days are over, let's finish the course. So these are things that we need to keep in mind in antibiotic stewardship. And please remember, it is the unit's responsibility to look at this data regularly and share it with all the health personnel. So with this quality improvement program that we had on antibiotic stewardship, we were able to reduce the use of antibiotics by almost 50%. Monitoring and surveillance is absolutely essential. Please don't be an ostrich and not look into your infection rates. You have to look at every infection which occurs, and every infection you need to do a root cause analysis and try to find out the reason why this baby got an infection, and not say that, oh, this is a preterm, he's at risk, his skin is not mature, he doesn't have immunoglobulins, poor fellow got an infection. No, there has to be a human reason. why this baby got an infection, and it is up to us to find it, and root cause analysis will help us arrive at it, and therefore we can improve our practice. So for this, looking at your own cultures, in fact, having something like a chart in your unit which shows your bloodstream infections is important, so that it hits you on your face, and therefore you can take steps to reduce it. And this is what our, I would say, our team, our HICC team of the NICU, we have a great team in the NICU, mainly driven by nurses who bring about such great data and show it and do things to reduce infections every minute. And every month we have such a presentation, but this sort of dashboard is available for us to see, where you have everything which sort of fits, looks at the NICU infection control program. How many admissions, what was the daily census, what were your death rates, DAMA rates, antibiotic days, nil per oral days, what were your infection rates, BSI, CLABSI, VAP, how many nurses were there. These are things which will all result in changes in your infection outcomes, and therefore it is important to see them and also look at even hand hygiene compliance. Such a dashboard, which I'm really proud of and I congratulate my team, is something that each NICU should have. In St. John's, we also do continuous surveillance. We had some issues with the MDRO bugs, which I'm sure many units have. So since then, we have been doing routine surveillance every Tuesday. We send the axilla and the umbilical and rectal swabs of all babies in the NICU and see if they're colonized by multi-drug resistant organisms, particularly meropenem resistant or MRSA. And if they have this bug on their body, they are still not suffering from infection, they're just colonized. We cohort them, we isolate them till they are discharged. And we have found that doing this sort of surveillance and cohorting and isolation has helped us pick up these bugs early. And we also give them chlorhexidine bath to reduce their bugs on their bodies. We can't do anything about the rectal swab, but on the skin, we definitely do it. And we found that by this intervention, our infections by MDRO has definitely reduced, and particularly the adverse outcomes. And when we say that death or DAMA in these babies have definitely reduced since our intervention. So this is how we have our isolation. And in the isolation, we have a 1:2 nursing. It's a negative pressure room. And in isolation, we always wear separate gowns, cap, mask. And all the babies here get 2% chlorhexidine scrub for 3 days. And they're cohorted here till discharge. The next big thing is standard precautions, something that I feel nurses know better than doctors. So what are standard precautions? They are a set of infection control practices used to protect healthcare providers from infection and prevent the spread of infection from patient to patient. So in this, we have personal protective equipment, gloves, goggles, gown, mask, and in this COVID era, I think all of you all know this very, very well. Cough etiquette, respiratory hygiene, these are some things that we all need to learn and practice well. And transmission-based precautions will depend on what are you dealing with. Currently with COVID, we're looking at droplet infections. And again here, I will be sharing the specific precautions for each kind of transmission later in the group. The next 4 things that I'm going to be talking about are something that will actually need much details. One is housekeeping, which again, nurses know better than doctors. What are the environmental routines that you need to do? And these things should be specific for your NICU. For example, our housekeeping protocol looks at what is the area that we are looking at, what procedure, what is the frequency we need to do the routine, and who does it. And we found that our phone was one of the most infected parts, so we have highlighted that in red. And these are the areas that we need to care for. Again, we will share these things on the group so that you can see and help develop things for your own unit. Similarly, disinfection and sterilization, every equipment in the NICU should have its own protocol for disinfection and sterilization. This is again very, very important to prevent spread of infection. Have adequate disposables. I think we are in an era where syringes is not a problem. When I was a resident, even those were issues. But even now, sometimes, even in my own unit, we sometimes, reuse circuits. Of course, we gas sterilize them in between, but reuse of any disposable items is actually not really recommended. We should have enough disposables to ensure that our infection control program is going on well. The next big thing is, and I've kept it for the last because sometimes you all can't do much about it individually, and that is the adequate nurse-baby ratio. In my unit, I have the luxury of refusing admission if we are full, but I know that's not possible in many other setups. And seeing babies, like 3-4 babies in a warmer sometimes is the norm, but this should not happen. We should have a 1 baby, 1 warmer policy. And if you're in a very high volume setup, then change your admission policy. Like maybe you can reduce your weight criteria for admission from 1.8 to even 1.6 and try to take care of the babies who are slightly bigger outside so that you don't have overcrowding in your NICU. Similarly, try to have an adequate nurse-baby ratio. I know all our units struggle with this, but what we do to improve on this is share your infection control data, infection culture positive data with the administrators along with your nursing ratios, especially at the times when you find that your nurses numbers were less and infections were more. Share that and see this is what we have a problem with, and you can use the NNF recommendations which talk about very high nursing ratios, almost 1:1 for ventilated babies, 1:4 for slightly sicker babies. So use those criteria and use the infections which unfortunately have happened because of an inadequate nurse-baby ratio to improve your nurse recruitment to the NICU. Infection control is not easy, but with a good teamwork, it's definitely possible. And the most important member of this team is you, the nurse. A team has to work well, and I'm so proud of our infection control team in St. John's Hospital, led by Dr. Bharti, who you'll be listening to in another lecture, and Sister Sophia. A good infection control program will definitely bring a lot of laurels for us. It has brought in the best NICU consistently for many years now. But the most important, I would think, prize is to see that your babies are safe. Since we started our infection control program, it was actually given as a DM thesis for a student. Our neonatal mortality had reached its lowest. So this is where is the most satisfying to see our babies do well and go home. So my key messages are the top 5 interventions that I talked about to reduce infections. And first and foremost is that infection prevention is in your hands. So thank you very much and take care. And please use the next 3 days to ask as many questions in the group. Our entire team is there at your disposal to answer it night and day. And I hope we have a great time together. Thank you very much.